Not here for a laugh. We're going to continue with the next debate, how to transform facilities in the digital age.
Now, I will ask Françoise Delettre, Mathieu Fouquet, Lamine Garbi, David Gruson, and Vincent Olivier will be the moderator.
Bien, bonjour à toutes, bonjour à tous. Nous allons maintenant nous intéresser aux enjeux du numérique.
Good morning, everyone. Now we're going to talk about the stakes of the digital age. And perhaps we thought too quickly that digitalization was going to transform everything. And then we realized that it wasn't the case. But we do see that digitalization has absolutely permeated the world of healthcare. We have connected objects. These are a reality today. And the first consequence of this arrival of the digitalization is that the notions of time and space have been eliminated. We can have remote surgery with a patient in Buenos Aires and a doctor in Paris or Strasbourg. So time is also eliminated. Digital time is the same for everyone. And we know this in the hospital. And when I'm thinking of hospitals, I'm thinking of all healthcare facilities, whether it's clinics, public or private hospitals, retirement homes, or all types of convalescent homes. So when I say the hospital, I mean, in general, a healthcare facility. Now, time is different because we have the time of the patient before, during, and after hospitalization. We have the doctor's time, which is not always doesn't always coincide with the patient's time. We know that there's some conflicts. There's also the economic time, invoicing, depreciation, investments. There's the administration time. And we'll see that administrators don't have the same notion of time as doctors. And then there's the legal working time in France, the 35-hour work week, which does pose problems in the French hospitals. So this is why this combination of time and space is challenged by digitalization, which forces us to completely rethink our relations with time and space. So we're going to talk together at this roundtable about how we can transform the facilities together. Could you give me an example of recent digitalization in your establishment? Well, you talked about patient's time. Obviously, digitalization should serve the professionals, healthcare professionals in our facilities. But often, people talk about the emergency ward. How long am I going to wait? Are there a lot of people in the emergency ward? And so we launched a little application that's quite simple. For each facility, you can see waiting time in the emergency ward. So you see in facility 1, waiting time is 0. In the second, 11 minutes. The third, 27 minutes. And the fourth, 36 minutes. So depending on where you live, you can actually be informed in real time of the waiting time in your local emergency wards. Obviously, patients don't all stay the same time, so it is an average. But this is a simple example that we can offer patients that really is beneficial for them. Jean-Louis Touraine, can you give me an example? Yes. There's one example that I find very significant, which in the retirement homes in France, so these are establishments for the dependent elderly. We can avoid, in most cases, useless travel by these patients to the emergency wards in the hospitals. When you're in a retirement home for a dependent elderly and the patient is not well, up until now, we transported them to the local emergency ward, and this caused disorientation due to their age and due to the very different atmosphere in the emergency ward. And then the patient was transported back the next day to his own home for the elderly in the conditions that were very disturbing sometimes. Today, there are links that we've set up between the emergency rescue services, the medical personnel, and the retirement homes. And in half of the cases, thanks to this coordination, the medical staff can actually come into the retirement home and do some of the necessary medical gestures without having to take the patient to the emergency ward. So it's a huge improvement for our retirement homes and also an improvement for the emergency ward. So that's an overall gain. Yes, an overall improvement. Françoise, can you tell us some of the digital challenges? Well, we are in charge of real estate, whether it's building real estate, designing real estate, or supervising the construction work or investment. We actually create the structure for the hospitals. So, but that's important. When you look at a hospital construction program, the hospitals that we deliver today were designed 10 years ago. So you can see that there's a real time lag between. In public hospitals, it's at least 10 years, and in private facilities, maybe 5 years. But between the time when we designed the building and we deliver, there's too much time. So we work together now with partners such as Philips, Siemens, and Cisco to work on these aspects. Let me give you an example. It's just as though today you went to purchase a cell phone and they sold you an iPhone 4. Yes, you can use it to telephone, and you can probably maybe send some emails, but you would be behind most of today's users. So that's today's problem that we have with hospital real estate. So yes, we need to anticipate problems that don't exist, and we need to follow as we design the hospitals. We need to follow these new technologies and adapt with very expert partners. So you work with banks, administrations, telecoms, and others. What are the classic resistance factors inherent to change? Well, there are several classic factors that we all know, and we have many tools to combat them. You have the resistance to new tools, the traumatism or shock of a new organization that was poorly deployed. You also have a resistance to processes sometimes. We also see a lack of feedback as to what was done in the past. People feel that they've been completely ignored when there's a new change with all of its impacts. Labor dialogue is not always satisfactory when changes are being implemented. So this maximizes resistance. And each sector also has its historical roadblocks that have slowed down this evolution. So you said resistance to the tools, past trauma. Do you experience this in your facilities as a resistance to change? Well, I would tend to say that there are very few places in recent decades which have adapted so fast as the hospitals. So I think we can be confident, we can be optimistic. Guy Valenciennes said in his introduction that this is just one phase in the human adventure, but hospitals have been able to integrate huge innovation. But this doesn't mean that we have to wait for everything to be ready. I think we need to try to anticipate. In the hospitals, we've never waited for financing or authorizations. Very often, people have launched things immediately. We create new treatments, and then we see how, in the end, we need to organize things to make them sustainable. And this is the same. The same is true for digital. And for French hospitals, public hospitals, the FHP, which is the public network of hospitals, there's this evolution of the GHTs. So this is what we call the territorial hospital groups, GHTs. So you group together all of the hospitals in a region, and you can imagine that what this meant in terms of dialogue. Each person had their own system in the past, information systems, and they all have to dialogue together because the same patient will be able to circulate among these hospitals now. So this was just like with the creation of the cell phone. We all have phones that we've purchased from different manufacturers. We have different subscriptions, but we can dialogue together. We send text messages, and it's not an obstacle. In the future, this challenge will have to be met by the hospitals, and not just public hospitals, but of course also for the links with private practice, with the patients, with the external world, and private clinics. And so that's a huge challenge. But I have no fear as to our capacity to meet this challenge. Obviously, we will need specific resources for digitalization of these GHT territorial hospital groups, but I don't see any particular resistance that would develop to combat this. We'll come back to that. Have you sometimes seen resistance phenomena that are classic in any organization, not necessarily healthcare organizations? Oh, I think the resistances are the same. Our partners, our employees, the doctors, the resistances are the same. let's come back to the pharmacists. I'm a pharmacist, and pharmacy has a great future. Someone mentioned that a robot would be replacing all of the pharmacists. I don't think that should be imagined. So I like Nicolas, and I like what he said, but there are many services that are provided by human pharmacists. And pharmacists have succeeded in connecting themselves with IT tools, and now we've showed this. Jean-Louis, as you said, these new GHT groups will have to dialogue with the same IT protocols and language, and that is a challenge, but it's a wonderful challenge. It's a positive challenge. Today, we can't live without our smartphones. We do everything with them. We rent cars. We take airplanes. Why couldn't we record our hospitalization and choose a particular ward and choose the time? And then why couldn't we have patient follow-up on the smartphone? So beyond the difficulties that we have in the field, I think tomorrow we should be able to have fluidity, and that all of this paper that we're all working with, we still need the paper. We hope that paper will disappear. Mathieu, do you see any specific resistances in your field? Well, specific to the healthcare sector, I'm not sure. And I'd like to react to what was said. All of the areas of resistance that we've mentioned, I think, are cross-cutting. When we help people transform organizations, we see them in every type of organization that are experiencing important change. But I won't talk about resistance, but perhaps there's specific attention that needs to be paid to these generational impact. When you talk about digital, this means a diversity in the organization that is different. Pascal Pic was talking a lot about diversity, and within this diversity, it's not just the difference in people's origin, it's also difference in the human beings. Some are working with artificial intelligence, other with robots. This generates fears. It's not necessarily a resistance, but it does require a lot of support for this new diversity. Jean-Louis, yes, I'd like to react to that because that's absolutely correct. It's not a question of resistance in the usual sense. You have to be very vigilant to something that's perhaps more cultural or psychological. Doctors, and especially nurses, can legitimately fear that a part of the time devoted to human contact with the patient will be transferred to contact with machines. And this is perceived sometimes as a bit bureaucratic and administrative and less of an interpersonal relationship with human beings. So I think we have to be very careful to preserve this because we're already hearing this fear expressed in our healthcare facilities, and even more from the nurses than from the doctors, but we hear it from both. It's not what we've been trained for. This is what people are saying. This is not our vocation. This is not our aspiration. So yes, people say, yes, we're modern. We can accept this, but don't take away from us this wealth, this richness of human contact. So that's the challenge, is to be able to combine this and help people understand that it's complementary, but it won't be deducted from these human contacts. Yes, the question I wanted to ask you is, how do you conceive the evolution of professions and each person's relationship with digital concerning the medical sector and paramedical sector and the administration? How do you see this evolution? Well, for us, what's really important is information sharing, traceability. Today, you can have traceability in medical records, but it's not perfect. And the private practice doctor should be able to connect to the patient's history and his record in the database of the healthcare facility and see and follow his clinical condition of the patients in real time. And this is vital. No, it's not a question of a big brother who's going to trace everything or know everything. No. Sometimes people worry about undesirable events being recorded, but this is part of life. I think we need to be more transparent, and quality of healthcare requires transparency, and digital can ensure strong traceability. And without this traceability, we can't make progress. And sharing information with all of the partners, whether it's the public sector, the associations, the doctors in their private practices, it's fundamental for us, and I think we're going in this direction. So information represents power. The doctors used to have the information, and the nurses didn't weren't party to this information sometimes. And so, yes, in the old days, the surgeon used to enter the patient's room and sit on the bed and in an all-powerful way. I think that those days are over. Yes, it's important that hospitals, whether public or private facilities, be really integrated in the city and in private practice. And we need different ways of working, and all healthcare professionals, doctors, nurses, everyone should have another approach and work differently. I think we need places for conviviality. Recently, we've had evolutions on office equipment, and today we're in what we call flex offices where people can meet each other more, and they don't have their own personal desk. And I think in hospitals, people are still too traditional in their offices with closed doors. So we need to change this as well. We've seen certain interesting changes in the Netherlands and in other countries with new types of structures where people are more interactive. And so when we create these boxes, these new hospitals, they need to be adapted to these new ways of working. And obviously there will be robots doing a certain number of things, but the healthcare personnel will be able to devote themselves more to the patients, and there will be communities that can be created between patients with the healthcare professionals with more contact, maybe rooms where they can meet more easily together. So you say that in the Netherlands there are hospitals where, yes, they've adopted this flex office concept. Have you seen this in France? Well, as Françoise was saying, between the creation and of a hospital that we're building, we all have projects underway. Between the time of design and the actual construction, people have changed their minds 10 times. And even during the construction, we change. Even when the building permit has been validated, we need to change things, revise things, because things change fast today. And digital allows us to really do this. When you talk about outpatient surgery, it's just 2 or 3 hours in the facility. And this allows us just to give a patient a badge and to know where the patient is in the facility, in what ward. Is he in the operating room? Is he in the resuscitation room? Is he resting? This allows the family to find the patient more easily and the teams to find the patient more, because often people say, oh, it's the guy who carried in the stretcher who lost the patient. And the this poor stretcher carrier is no longer the scapegoat. Well, in terms of patient safety, security, no one doubts that digital is a huge progress. And it's obvious that, let's take the example, of a study that the FHP, our foundation, has financed for adherence to treatment. Young people, young teenagers, for example, with cystic fibrosis have been using this type of traceability. And we know that with these chronic diseases, adherence to treatment is the main factor for failure. And here we will have a way not to eliminate it, but to reduce the problem of adherence with an immediate alert when the patient is not adhering to their treatment, and then provide the appropriate correction, either through telemedicine or through direct contact with the patient. And I simply, if I have one more second, would like to tell one story that comes to my mind that really illustrates the advantages of what we need to do to preserve the application of this miraculous tool. A patient that I hadn't seen for several years came back to see me, and in the interval, she had seen one of my assistants, and I asked the patient about my assistant. Oh, he's wonderful. He talks about figures and treatments. He knows everything in my record. It's miraculous. She had never seen a doctor like this, and even she was saying between the lines that this doctor knew more than me. But there was just one thing, she said, that during the entire visit, he never looked me in the eye. He was always looking at his screen. So we see that you need to continue to use digital, but a little human contact with the eyes is also important.
So coming back to human beings, it's what we were saying previously. What is the human factor that remains? Are we just hiding behind the digital technology? I don't think that's the way we should see things. I think there's, we're going through this digital tsunami, but we need the human factor. Digital technology facilitates things, but it doesn't replace the human factor. You can have a number of organizations being destroyed, but others are being created. The advantage of digital technology is that you can shorten the administrative time. You can collect data. We wouldn't be able to do this just with human beings. It means that there is more time for relationships. So relationships with the patient especially. But there's something else I'd like to say. In organizations, it means there is more time for staff as well, for the medical staff. The medical staff, and that's important. And there are fewer silos in what we have been doing. Some have been successful, some have been less successful. But what we're seeing is that we've broken down silo-based organizations that didn't speak to each other, to the benefit of organizations based on digital technology, communities. This means that we've got these new communities, these new groups that are sized according to their needs. They're very open. There's no, you don't belong just to one community and not to the others. People are working together. So these communities are changing all the time. And this means that we've got a better relationship. People belong to different communities. There's a constant cultural input, and these communities are flexible, and they, speak to people inside and outside the community. So let's come back to the notion of the quest for meaning. It's important to think that from an individual and collective point of view, it's not just about technological progress. You have to have meaning. What does it mean for me as an individual, but also what does it mean for the organization? How can we articulate this sense of meaning? Today, we're building fewer square meters, there are fewer beds, and we have these communities that are being created. And the communities don't stay just within the hospital walls. We've heard this. They extend to private practices, etc. And that's important. We've got some great productivity gains thanks to this. And having connected facilities in the future, connected with private practices, this means that we're going to be much more productive. And when we build a facility, we take into account quality requirements, safety requirements, environmental requirements. In Paris, in the Ile-de-France, this is what we're saying. We can measure the air outside, and we work with the organization to measure the air inside the facilities. So we have many, many means of improving how the whole thing works, so that the patient receives better treatment and so that the human being is really there to help the patient. Now let's talk about companies with services dedicated to care. So we're not talking about reducing staff. We need to have people who are working with patients, who are providing care. In terms of the discussion among ourselves, I have a question for Jean-Louis. Jean-Louis, you talked about the local hospital groups, and we've got our different regions that have been created for 20 years. We've been thinking about this kind of setup. Jean-Louis, in the future, will we be able to talk to each other between the local hospital groups and the clinic that's just next door? Well, why not? Why wait until the future? I think we can do it already. So we'll talk about that maybe next year. So the right geographic scale in terms of digital technology. Is it the local focus? Does it relate to the regional health agencies? What is the right geographic scale for digital technology to take on its full meaning? It's not an easy question. Well, coming back to health, I don't think, everything is homogeneous across the different regions. And it's the same thing for digital technology. There are at least two dimensions here. There's a first dimension, about being close to people, GPs who are looking after patients with a chronic disease, in contact with a public or private ward. And then there's this small network with the different healthcare professionals. And then there is the broader dimension at regional level. Now, this has been defined in various ways. I think it's absolutely necessary for the dialogue to work between all of these different elements. And that dialogue has an additional requirement. People are more isolated than the past. Families are smaller, people are spread across the nation and the world. So there are many elderly people who are fairly isolated. if, thanks to connected objects, thanks to these networks, thanks to this real or virtual proximity, these people feel close to healthcare professionals. And I'm talking about healthcare generally. If these tools are made available to fight against such isolation, then I think that they will have certainly fulfilled a great function in terms of healthcare, but also prevention. Yes, I agree. Digital technology can bring people who are isolated closer to the healthcare world. Very often in restaurants, you've got tables of people, 3 or 4 people, and they don't speak to other tables. So this is important. This is what you were saying, Jean-Louis, about the contact with the patient and with human beings. Digital technology is also a vector of traceability, and it's important that the technology doesn't set up silos or obstacles. Yes, computers are obviously not going to replace the coffee machine. What are the success factors if we want to transform facilities thanks to digital technology? We've talked a lot about feedback, the feedback from the person using these new digital technologies. You know, they need to be able to say what they think about this. Is something that we don't have in hospitals. Yes, once again, there are specific aspects relating to each sector. There's something, I'm sorry to say this, but in the transformation of facilities that we're seeing, the only way to be efficient is to have co-building right from the start. So before even having feedback, there's the notion of listening and talking with all of those involved so that they have their they say what they think. That's very important. And then, of course, it's important to have feedback. We're also seeing, now, obviously, this depends on the sector, but we're also seeing that there's a danger that we have to be attentive to. We've got this organizational transformation thanks to digital technology, but then there is the idea of testing zones, testing organizations, testing new tools. And with this test phase, we're often excluding the surrounding aspects. So the test phase means that we can add modifications, but we mustn't move too far away from reality. So in transformations that work, things go very fast. We spend a lot of time listening. The solutions are set up fairly quickly thanks to the digital technologies. And very often we do this at large scale. Very often there are problems, but we've seen that it's more efficient to look at things globally and to deal with local problems rather than work on an iterative basis, because the digital technologies and tools mean that there are different budgets and it's very difficult to manage. So coming back to digital technology, a tablet or a mobile phone, these are not shields, they're not walls between colleagues or with the patients. On the contrary, let me give you an example of what I'm doing at the moment for human resources. It's great. We're looking at the annual appraisals. We're defining them. I can see the reaction from the public. We're doing it. We're in the process of doing it. We don't need them anymore. We don't need them anymore because people talk to each other. I think that digital technologies involve not the same people. The center of gravity is different. There are other organizations that are not necessarily in that sector where you have an annual appraisal. Once a year, you decree that, okay, let's explain your problems. Let's explain how you're satisfied. You don't talk about money. And often this is something that you do with somebody who you don't necessarily know very well. So when we wanted to transform organizations by bringing down the silos and having much more horizontal structures and putting individuals at the center of the system, we said to ourselves, okay, we can't keep at this top-down structure, but there are much flatter structures. So we did this, we focused on this, we reversed the system. So basically now it's employees who manage their own appraisal. They ask for the feedback. So we've created an application, and employees go through 4 phases. They look at their own indicators that they fill in themselves, how long it's been since they had holidays, if there are any warning lights. There's a second part where they receive feedback from their leaders or managers, and peers. And so they say the feedback, they see the feedback from their colleagues. So there's a permanent dialogue. It's not just a digital exchange, and it's not about just saying you've been good or you've been bad. There's feedback, but there are no answers. There's just the possibility of being in contact with somebody, and so the employee can explain what they feel. And then the third part concerns achievements. Increasingly, well, for years now, we've been giving marks, scores. We say, okay, this objective hasn't been achieved, or it's only been achieved to the extent of 92%. So you talk about achieving group achievements and also individual achievements. And this is where they hear that if they've been very good in certain areas, they need to focus on those areas. So even if this is not traditional, this is what digital technology makes possible. And then there's the fourth part. There's a part called, I don't like the term, but it's called SOS. So as an individual, I don't feel very comfortable, and I need to say it. But perhaps it's not because of my manager. It's not because of human resources. It's not because of my colleagues. So you send out an SOS, and after that, there's a system that provides a meeting time that allowing the person to see somebody straight away. So all of the managers who are supposed to carry out these appraisals, and it's a real headache for them, and they've got to close their budgets, etc. The digital technology allows them to save time. It's the employee who is in charge of the appraisal from A to Z. Let me just finish with one last thing. Since the baby boom, our organizations have been based on obligations of means, stable organizations. So you've got your production means that are serving a group. I accept these, but in exchange, I have health, security, work. Then we've got the digital tsunami. You've got this generational divide. You've got people who no longer accept imposed groups. They want to choose their groups. So smaller groups, they need to feel that they exist. They don't want any more paper, and they want to have more time and see more meaning. So this appraisal. So you are talking about having appraisals with peers. It's bottom-up rather than top-down. How do you feel about this? Well, there's a lot of hypocrisy with these annual appraisals, and I'm in favor of simplifying them. But also, they have to serve human resources. We developed a tool that is very good. So we're, working 24 hours a day, and there are always people who are absent because there is a family event or they're ill. So we've developed an application that makes it possible when a professional has a problem, there's a warning light that goes off. So we can replace people within 2 days. So we've got a kind of an internal pool. People are warned by text message when there's a problem, when there's somebody who is absent. So this means that we have more time, we're more efficient, and they can take the replacement or not. They can help out or not. And IT systems help us with this, and they offer a great tool. There's another subject that's very important. Perhaps we're really at the start of the development of this kind of tool when it comes to relations between professionals and their appraisals. As was suggested, it can be the best or the worst kind of experience. It can be used to exert permanent pressure, and the psychosocial disorders in these facilities can be increased if people feel that there's Big Brother breathing down their neck all the time, making sure that they're working properly in an efficient manner. So he presented the positive side of things, and I agree with that. And I think it's a good idea to have these appraisals. It's good if there are issues to be dealt with. So the tool is not entirely mature. It needs to be developed a little bit more. And I think it's important to find the right kind of formula for the future. So we need to make sure that individuals feel fulfilled. And I think the solution is remarkable. I hadn't heard about it. Being able to call on people for help, an SOS. Now, with my experience, very often people only call out for help very late in the day. To call out for help, you already have to have gone through a whole series of difficulties that you've tried to overcome. You've got to have faced some terrible difficulties, and really, when you get to the end of your tether, that's when you call out for help. So you have to find a means of anticipating all of this. The links between professionals. Now, of course, hospitals are focused on patients. That's the main objective. The main focus is the patient. And the quality of the services provided cannot be good if the professionals don't feel fulfilled, if they're not comfortable with what they do. So it's absolutely essential that in the way we design tools in the future, we keep in mind that nobody must be forgotten or neglected. Nobody must be placed in a position of difficulty. Each person must be able to bounce back after a difficulty while keeping a certain share of confidentiality. Let me come back to something. So upstream, would it be good to have personnel involved in the development of digital technologies and tools? So I have the impression that you've got the first users who need to be satisfied. Am I wrong? Or is this what's happening? Are personnel involved? In the building of facilities? No. The users are very much consulted. I wanted just to come back to annual appraisals in the broad sense of the term. This is something that's conditioned by the working space. If you leave your silos in place, the little offices, it won't work. So you have to have a dynamic environment and have people who talk to each other, who are together working on the same platform. That's very important. In some healthcare structures, planning is digital because you can see that things are changing. It's complicated, but how do you make sure that the digital tools are appropriated by the people using them, and that things are done before they're set up rather than afterwards? You were talking about the operating ward, or so this appropriation is virtual. So the change happens easily with the new generation. The new generations are very much adapted to this. So cameras, televisions, remote operations. These are things that are done often today. In an operating theatre, I don't know. I think operating theatres are different. So our operating theatres have to be the same to be able to have that kind of use of digital technology. So, in other words, we work with private practice doctors, and they work in partnership with the clinic. But there are no more offices. The physical offices, they don't exist anymore. You need, obviously, a room to meet up from time to time. But as we work on different sites, we have different jobs. The office is basically the digital technology used. So then you've got the public power that you have to keep in mind. I don't like contradictions. The healthcare law introduced by our old former minister has reduced access to data. We no longer have access to data, and that is an obstacle. The other positive sign is this morning. It's what I was saying. You have you're going to have federations, 100 million euros for developing digital technology as a part of the PRFS. So there are some positive signs, and I think that we will be able to continue to develop because finance people, they provide a driving force, and the digital hospital will contribute with this. They will help us to equip ourselves and harness this technology.
We talked about distance medicine. Of course, that's already done at the present time. A patient can be at home and connected and get connected. We did an experiment in our offices. We installed a telemedicine booth. So there are two types of consultations. Either our employees come in and we take their blood pressure and a few examinations, or there's a real consultation with a physician who's behind the television screen who takes the time to see what's going on. There are sensors for examining the person, and then there's a prescription that's produced. Now, this type of thing, we're developing it with a company, and this company is also developing abroad and is trying to develop in France. And we have not yet managed today to have this consultation be reimbursed by the Social Security. But it's a normal consultation, just like going to see a physician. It facilitates appointments. It makes lots of things easier. The prescription is valid, yes, of course, but it's somewhat unfortunate that there are these roadblocks because in isolated places, in other places, these telemedicine booths would be very useful. And abroad, it's considered to be a normal consultation. It's a question of the pricing. Now, we can agree that on what basis are we going to create the rates? But there are signals, there are current signals that are positive in this direction. We mustn't wait for everything to be resolved with a magic wand. We've already started looking at pricing, which is progressively increasing for telemedicine related services. So I think that we can expect all of this to be progressively put into place. Of course it's long, because as in our system, and that's the way it is, everything is covered. Globally, it's clear that there's an assessment, there's an impact study, if you like, that was performed to figure out how much it costs and to see what the expenses are going to be, and if the sums incurred and the sums used are going to be comparable with what was done in the past. This is just like when there are new immunology treatments, or the pricing is not immediate. We have to have some time in order to ensure the scope of the demand and the overall cost. So it's true, we can regret this. Yes, I'm the first one to regret it. This inertia, this slowness. Of course, it's regrettable, but nevertheless, it's rare for something as necessary or something as indispensable or something so open-ended as what we're talking about here today will not, perhaps with some a year late, eventually it will have appropriate rating and pricing. To answer your question, Vincent, on the appropriation by operating theaters, we also have our successes and failures. And internal management is all part of it, but I think that the fundamental product is simple, because that's what we want, simplicity. If we have to have a full open four menus, click on this and click on that and validate it, and then we have to have three days for an alert to come through, or if there's a lot of programming we have to do, it won't work. And the criticism will always be the same. We don't have time to do this. And individual physicians will say, you're imposing a system on us that's too complicated. We can't communicate with them. So when we have a good product, and they exist, fortunately, it's magical. It's marvelous. There is an obligation today for the new generation of metaphysicians to have results. It's something that has to be efficient. In my generation, how do you perceive this and the medical and related medical technologies? You have to appropriate new instruments. Now, of course, we have to have a new relation with work and to the time related to work. I would say that people who are nostalgia for practices of the past are wrong and must never forget that the results of the past were not as good as the results we're getting today. So, on the contrary, we have to adapt to this evolution, and I think very naturally the new generation has different requirements, different demands. We see it when we talk about in other medical fields and inequality of access and territorial inequality of access. We see that there's a nostalgia in the way we perform, but in any case, it will not come back, and we have to accept it. The new generation of practitioners wants to have work time, which is intense, efficient, but also leisure time, which are quite separate. They don't want to go establish themselves in places where there's nothing there. They want to, for your families and their children, they want to have things for your families and children. Now, all of this, of course, we mustn't forget this. It's very simple, I think, to say that we have to audition the new generations of students in-house, and to see what are their different hopes compared to the past, deal with these things and ask them in exchange to fulfill the missions that are necessary. And in the specifications, naturally, there's all the digitization, of course. We don't have a lot of time yet, but we're going to talk about patients a little bit. We're going to talk what we do so that the patient, so that the patients will also appropriate these digital tools. How can we get the patients involved Not an equal footing, perhaps, but the cooperation, perhaps, as Matthew was saying. So, well, how can we expand this within the general public? It has to be simple and accessible. That's easy. Just to come back to our practitioners, it's true that they work more, faster, and for less time, or often only 4 days. So we have to adapt. So the service that we offer organizationally is up to their expectations and also to the medical quality, because today medical quality is important. And we have to remember that, because a clinic without a physician is just a hotel. And I don't think that we would have the success that we have these days. And patients, what they're asking for, they're different patients. There are patients who, in so out of the way areas, their impression is different from somebody who's in Paris. Some people don't have smartphones, so we have to think of that as well. So we have to be an engine for new developments, for new suggestions for people who want to make online appointments and who want to manage their own hospitalization. But we mustn't forget that some patients come to our establishments and they don't know who they're going to be operated on. They don't know who's going to do the operation. They know they're going to the establishment. They're trusting in the emergency ward, and they expect to be treated by someone properly, but they don't know who. We have to put this in mind. It has to be simple and legible, understandable, and they have to want to appropriate these tools. A few years ago, you had to have a semi-hybrid. There were several hybrids and several levels of acceptance and appropriation of tools by the current generations. But it's obvious that the people who are young today, in 20 years, they won't be as young. It will be the patients the patients of the future. So these people, there's going to be a great deal of homogeneity. The connected objects and the facility for use these tools will exist for almost everyone. Now today, however, we have to take into account the fact that there's somewhat of a hybrid system. There are people who want to anticipate and go further with the use of these tools, and others who are somewhat more hesitant. And they say that they don't have the education for it. They all want, however, to be able to maintain a certain confidentiality in the data. So we have to bear that in mind. Yes, we're getting to that point. Now we're talking about data sharing and patients and collection of data and transmission of data. We're going to see the linkage between the patient who provides data and the physician at the hospital and the medical machinery. What's going to come in the future in any event. We're almost there. It's almost a reality today as it is. Confidentiality is a topic which is a very important but somewhat taboo. It mustn't be at the forefront, otherwise we won't advance. So the number of data that we're getting today on the medical data on social networks is huge already. And to be able to protect the systems, protecting too much can mean that we don't advance either. But I think it's quite essential. I was one of the members of the experts group on the health plans, but this nation of data is fundamental. 3/4 of the French today do not want to share their data with private health companies. Google or Facebook, okay, that's one thing. But I ask you to ask very quickly. So how can we protect these data? Because protecting this data is fundamental. Do we have the means? Are we going to have to abandon them? Well, we only have like a minute to answer. It's a fundamental question. If people don't appropriate this technology, they won't do it. Of course, there's a regulator, but it's going to add a burden to the system. But there's going to be an ethics charter. There can be a regulator. On the public side, there can be things like that. But it's true. It's somewhat burdensome, and it's a subject. There's protection we can't absolutely protect absolute health data at 100%. We have to define. We have to be. There has to be penalties for people who use them improperly. I think in this way there will be fewer people who will risk want to go hack into the data. So that's why perhaps some patients don't want to share their data too much. Just the last word. When you're talking about on the patient with the hospital staff, it's that digital gives time. So this is the proof. The common denominator between the professional and the patient today is also the digital footprint. They have to understand each other as well. We have to ally thanks to the digital technology. Thank you very much to everyone. Thank you.